So, hello friends. So, I'll be taking you through a case vignette of ischemic bowel that I was asked to present as a case vignette in Gorakhpur, UP Kritikon. So, I'll just take you through a real-time case that we had in our ICU. And ischemic bowel is a fairly common condition, and it is imperative that we have a systematic approach to managing this. And we'll try to delineate the differences of ischemic bowel and septic ileus. So this is what I was asked to talk on. So this was a 70-year-old female with a diabetic, hypertension, and coronary artery disease. So came with severe acute abdominal pain of 1 day with a bloody diarrhea and being acutely unwell. So the question one should ask oneself is, what are the differential diagnoses when someone comes with this situation? So any abdominal pain, I tell everyone that it's a Pandora's box because the differential diagnosis can be quite huge and quite enormous. So it is good to go in some sort of a systematic format with regards to structures so that we pick off the possibilities. So any abdominal pain, we could differentiate into whether it's acute or chronic. So coming from top to bottom, so it could be esophagitis, it could be peptic ulcer disease, or it could be colitis and ischemic bowel. So you just come from top to bottom, sticking to GI tract and out of the GI tract. Or it could be just an impacted feces, which itself can cause acute abdominal pain or bowel obstruction. So the commoner ones we tend to see in ICU is bowel obstruction, sometimes fecal impaction, and ischemic bowel, especially in elderly patients. We need to entertain this sort of a possibility of ischemic gut. We'll talk about it. But another common one with GI bleed can be diverticulous. In fact, just a week back, I had my neighbor in an apartment who had a torrential sort of a lower GI bleed, came with hypotension to ICU, and then the endoscopy revealed a lot of diverticulosis and diverticulitis. So, which means this is also not uncommon, more common in the Western countries, but even in India, this is a possibility. So, with regards to the GI tract, these are the possibilities one could think of. Out of the GI tract, of course, you have to think of pancreatitis or someone is diabetes, which this lady was. You may have to think of DKA coming with abdominal pain or peritonitis, especially if someone has an underlying liver disease or some hollow viscous perforation. Or one has to look at any gallbladder calculi leading to cholecystitis and abdominal pain. Or it could be ileocecal ileitis or appendicitis. And even the kidney stones also can cause abdominal pain, so nephrolithiasis. So these are the structures in the abdomen out of the GI tract which could lead to abdominal pain. Then there are conditions out of the whole GI system itself which can cause, like myocardial infarction can present with a sort of a pain which is localized to epigastric pain, which you would have all have heard of, or even sometimes pneumonias do present, lower lobe pneumonias do present with abdominal pain. So these are little offbeat sort of a causes which can manifest as abdos. But you have to keep your thoughts wide and have a differential approach that any of these could be contributing to the abdominal pain. So of course, when they come with abdominal pain, with vomiting or with diarrhea, with a sort of bloody stools, so you have to look at what are the relevant investigations and workup. So of course, in ICU, as a standard tool that we would do the complete blood counts and complete biochemistry. So if there is increase in white cell count, you would think of infection or inflammatory conditions, and of course, you will send blood cultures. And as a routine for any sick ICU patients, we would do kidney function tests and liver function tests. And arterial blood gas gives you insight whether there is an underlying lactic acidosis, which may point the signal towards the ischemic bowel and anion gap. And of course, you would do lipase and amylase to look for any pancreatitis and urine analysis to look for any UTIs or nephrolithiasis, so on and so forth. So coagulations profile is done to look for underlying sepsis and liver dysfunction and GI bleed. So these are the sort of investigations that intuitively you would think of to rule out the possible sort of to navigate your thoughts towards possible structural diagnosis. So these are the expected investigations you would do in IC. But I think the clinching, the diagnostic clinch would possibly happen with your imaging. So for this patient, obviously, we did an abdominal X-ray. It showed dilated bowel loops, as you see. And one has to look for any pneumatosis, intestinal air pockets within the colon. And this abdominal X-ray helps you to rule out ileus or hollow viscous perforation, especially when you have air under the diaphragm, or sometimes renal calculi also could be identified. Of course, this X-ray is having low sensitivity in establishing the diagnosis. So what about ultrasounds? Ultrasound is very valuable tool to look for any gallbladder calculi or renal calculi. And sometimes you can see a fecalith or a inflammatory mass at the appendix, which indicates to you whether it's a complicated or uncomplicated. So this was one study which sort of highlighted the value of ultrasound in complicated appendicitis. Especially ultrasound could be utilized to look at loss of echogenic submucosal layer. If there is loss of echogenic submucosal layer, had shown 100% sensitivity in recognizing complicated appendicitis with 92% specificity. So ultrasound still remains a reasonably good tool based on this study to look for complicated appendicitis, to look at the loss of echogenic submucosal layer. But I think for all the audience, you would agree now in this day and age, any pathology in the abdomen, if we have to identify with certainty, and abdomen being the Pandora's box with so many structures, CT remains at the end of the day a gold standard to try and identify with certainty and confirmation what is the possible problem. So there are studies. Basically, this was a study that came from Finland where they looked at CT as a imaging modality in patients over 65 years who come with abdominal pain. And they found with increasing age, the CT has a higher likelihood of establishing the diagnosis with certainty, and it appeared to be more cost effective. So this was another study that came from the French group where in elderly, especially in elderly patients who come with abdominal pain, we cannot limit our investigations only to abdominal X-ray and ultrasound to establish diagnosis. That is the message I want to convey to the audience. So CT, because this particular study, which was done in 405 patients, age more than 75 years. So in the emergency department, diagnosis improved from 76.8% to 85% by doing CT. So the message out to the audience is in elderly, have low threshold to do CT abdomen to establish diagnosis, and don't limit yourself to only biochemistry, chest X-ray or ultrasound, because you may miss the diagnosis from the structural standpoint in the abdomen is the message, and that is evidence-based. And even the treatment improved from 88.5% to 95.8% by doing early CT in elderly patients to establish diagnosis was what the studies showed. So this is the message I want to send across. And even CT abdomen was able to pick up unsuspected abdominal disease in 30.3, where this abdominal pathology was not thought of, was picked up in 30.3%, and 3.4% went on to get unexpected surgery based on the CT findings. So this is a very important slide. When someone elderly comes with abdominal pain, one should have a low threshold to do a CT scan, which will improve your diagnosis and which will improve or guide you and navigate you towards treatment paradigms and help you to establish diagnosis is what was shown in these particular studies. So, and CT is also 93% sensitive in picking up other structural problems like diverticulosis, and this sensitivity improves with oral contrast, and with enema, the sensitivity improves to 99%. So this patient, obviously, as you see, had a little dilated loops and with the features of ischemic bowel. So if you see in this patient, there was a cutoff of the middle part of the mesenteric. So there was an occlusion of the superior mesenteric artery, because you can see the mesenteric artery coming from the celiac axis. So there was an occlusion of mesenteric artery. And as you see, there is a loss of this contrast enhancement in the submucosal layer, indicating this patient had ischemic bowel. And this was the surgical findings where how the ischemic bowel looks, where the whole bowel looks very dusky. So, from the narrative that I've been speaking, so if someone comes, elderly person, diabetes, hypertension, especially with coronary artery disease, with the abdominal pain and bloody diarrhea and being very sick with high lactic acidosis, So one has to do early CT scan with contrast to try and establish diagnosis. And very commonly, we would miss this if we are beating around the bush trying to uh, pick some other sort of a possibility as the cause. So one should have a low threshold to do CT to pick up this diagnosis early on. And CT angiogram helps you to diagnose much better. So there's multi-detector row CT, which has a sensitivity of 96% to pick up non-occlusive mesenteric ischemia or mesenteric ischemia with specificity of 94%. So there is an entity. So not necessarily all the patients who present with abdominal pain with the findings can be obstructive mesenteric. There is an entity called non-occlusive mesenteric ischemia. 20% of them can have mesenteric ischemia due to non-occlusion of the mesenteric artery. So the risk factors are heart failure and any elderly patients with coronary artery disease. They're all at a risk of having these heart failure symptoms, arrhythmias, or aortic insufficiency and peripheral. Because as one gets elderly, there is a risk for vascular sort of a disease and narrowing of the vessels, which leads to mesenteric ischemia. And sepsis also is a risk factor for someone developing mesenteric ischemia or NOMI. And even it is shown pancreatitis and certain drugs like digoxin, alpha agonists, all these are at risk of putting someone at a risk for developing mesenteric ischemia. And someone who's on dialysis are also at a higher risk of developing mesenteric ischemia. And in youngsters, if someone is a cocaine addict or a opioid addict, they are also at a risk for vasoconstriction and non-occlusive mesenteric ischemia. So these are some of the causes. So any elderly have a low threshold to CT to establish the diagnosis and entertain and try to pick up the structural problem in abdomen. As I always say, abdomen is a Pandora's box. We need CT imaging to pick up the diagnosis very early on. Now coming to the last bit, so I was asked to highlight on key differentiators of bowel ischemia and septic ileus. And very often, friends, there is a huge clinical overlap. So it is impossible to delineate between ischemic bowel and septic ileus clinical. From the clinical standpoint, it's very difficult, but there are subtle differences if you look into the evidence. So the clinical abdominal pain in ischemic bowel is sudden and severe. In septic ileus, the abdominal pain is diffuse with abdominal distension. Because there is ileus, there's more of distension aspect in the septic ileus. Age, ischemic bowel tends to occur in older individuals with cardiovascular risk, but septic ileus can occur at any age and generally tends to occur in patients who've had recent surgery. That's why history is important. If someone has had a recent sort of abdominal surgery, they are at a risk of developing septic ileus, or when there is an underlying systemic infection that may lead to septic ileus. And biomarkers are helpful. D-dimers are higher, tends to go up in ischemic bowel, and it is non-specific in septic ileus. And it was shown in this particular study from Belgium, where D-dimers can be used to try as a surrogate marker for ischemic bowel. And we all know lactates tend to go up with ischemic bowel, but they are non-specific with septic ileus. CRP and procalcitonin, which is a markers of sepsis, tends to go up in septic ileus as opposed to ischemic bowel. And there was a study that came from Estonia which showed these can be some of the differentiators. And CT, dual energy CT, significantly enhances your diagnostic capability to pick up ischemic bowel. This was shown in this study from Japan. And contrast enhanced ultrasound also can be used as a tool for real-time assessment of ongoing vascular ischemia and ischemia. But the gold standard would be CT angiograph, which can ascertain the patency of the mesenteric vessels and possible occlusion of the mesenteric vessels. So the key aspect, friends, is the integration of the clinical lab parameters and imaging, which helps you clinch the diagnosis. There's no one golden rule, but the quintessence of establishing diagnosis comes from CT angiograph. So other markers can be used as an adjunct. So abdominal pain can be absent in 25% of the ischemic bowel. And as I said, mesenteric arteriography, which I showed you in the previous CT angiograph, showed the cutoff of the middle third of the superior mesenteric artery. When you do mesenteric arteriograph, you can see the occlusion or the non-patency of the mesenteric vessel here, as is shown with the arrow. So the goals of treatment is hemodynamic stabilization, correction of metabolic acidosis, antibiotics, and Rayleigh tube aspirations. And then you have to fix the underlying cause is the way to go. So this is all is there in the ischemic bowel. So the take home is any elderly patients with underlying cardiovascular disease of some nature, peripheral vascular disease, or who are on digoxin and who are having some sort of an arrhythmias or alpha agonists, they're all at a risk of developing ischemic bowel. And you have to integrate your clinical findings, most importantly, lab parameters. The lactate levels will sort of signal you towards possible underlying ischemic gut. And you can look at D dimer also as having a good negative predictive value. And the imaging remains gold standard with the contrast enhanced CT is what will clinch you the diagnosis, friends. So that's about it, friends. So thank you very much. So request you all to submit your valuable work to Children of Acute Care. So thank you. Thank you, wonderful.